prior to admission, the patient suffered pain at the right breast. She related the pain as 8 out of 10 and masses noted at the right breast. So a mammogram showed that the right breast is bigger than the left breast, and there is a cluster of pleomospeak in the subauricular region. This is associated with palpable masses biopsy, and biopsy was advised. On the laboratory results also showed breast mass of 9 mm ductal carcinoma. This is the final pathologic diagnosis of the patient. So for the tests and procedures that may use for breast cancer, this includes blood test, breast MRI, bone scan, CT scan, and the prescription emission. For the case of my patient, mammogram was used for the exam. And then we also have to consider for the stage of the patient. So the staging system is we have that TNM, which is the tumor, node, and metastasis. So dira ka basis para kung ma-identify kung unsa na na-stage ang mong breast cancer. So for the stage sa akong patient is T1 stage.
Good day, my name is Carmina Leaf Arson Hako, a fourth-year nursing student from Negros Oriental State University. And so for today, I will be talking or summarizing Binga-an's report. A case study in a patient with fluid and electrolyte imbalances presented by acute tubular necrosis. The purpose of the study was to provide deeper understanding and practical knowledge about fluid and electrolyte imbalances as presented by acute tubular necrosis. The case study gives emphasis on the definition, causes, signs and symptoms, risk factors, pathophysiology, complications, prevention, diagnosis, and treatment of the condition. Fluid and electrolyte balance is fundamental to the process of life. Abnormal fluid, volume, and electrolyte concentrations can seriously alter physiologic homeostasis and can be life-threatening. Although medical therapy to prevent increased fluid and electrolyte disturbances is the physician's responsibility, nurses play a major role in all aspects of patient care. Understanding how fluid and electrolyte disturbances occur and how the body compensates serves as a foundation for understanding many diseases and associated nursing management. Acute tubular necrosis is the most common cause of acute and renal failure. Early recognition of patients who are at risk for ADN can prevent or improve the course of ADN. Acute renal failure is classified as pre-renal, intrinsic, or post-renal disease. ATN is classified as a type of intrinsic renal disease. The clinical course of ADN is divided into the renal failure phase, diuretic phase, and recovery phase, with each phase having distinct symptoms and laboratory findings. Diagnosis of ADN often is complicated and confusing. Understanding of laboratory findings can facilitate the critical care of nurse ability to assess those at risk for ADN. So let me give you an overview of acute tubular necrosis. Acute tubular necrosis is a condition that causes the lack of oxygen and blood flow to the kidneys, damaging them. T-shaped structures in the kidneys called tubules filter out waste and fluid. These structures are damaged in acute tubular necrosis. When this happens, acute kidney failure may occur with electrolytes and fluids increasing in the body, possibly past safe levels. Causes: a small amount of urine output, swelling and fluid retention, nausea and vomiting, trouble waking up or drowsiness, feeling sluggish and confusion. Risk factors for acute tubular necrosis include situations where blood flow is cut off or reduced, as with blood cells, extended periods of low blood pressure or shock. Blood loss from surgery and trauma can also lead to acute tubular necrosis. Other risk factors are muscle damage and disease. For the symptoms, we have a small amount of liquid, swelling and fluid retention, nausea and vomiting, trouble with convulsions, feeling sluggish and confusion. Several tests can be used to diagnose renal failure. This includes blood indicators such as blood urine nitrogen, creatinine, and electrolyte levels such as calcium and potassium. The accumulation of these substances in the blood indicate that the kidneys are not working properly. Acute tubular necrosis is usually diagnosed by a nephrologist. For the treatment, treating the underlying cause is crucial in order to allow the kidneys to recover. While the kidneys can often self-heal, you may be required to follow some dietary restrictions that include limiting fluid, sodium, and potassium intake. This prevents the buildup of those substances while the kidneys are recovering. For the prevention, maintaining blood flow and oxygen to the kidneys can reduce the chance of developing acute tubular necrosis. If a test with contrast dye is needed, drink a lot of water beforehand or afterwards. Make sure your blood has been cross-matched before you receive transfusion. Work with your doctor to control the disease that can damage the kidneys, such as high blood pressure, diabetes, liver disease, and heart disease. Avoid over-the-counter anti-inflammatory medications such as naproxen sodium and ibuprofen, especially for the nursing intervention. Monitor fluid and electrolyte balance. The nurse monitors the patient's fluid and electrolyte levels and physical indicators of potential complications during all phases of the disorder. Reducing metabolic rate, bed rest is encouraged and fever and infection are prevented or treated promptly. Promoting pulmonary function, the patient is assisted to turn, cough, and take deep breaths frequently to prevent atelastic and respiratory tract infection. Preventing infection, asepsis is essential with the invasive lines and catheters to minimize the risk of infection and increase metabolism. Providing skin care, bathing the patient with cool water, frequent turning and keeping the skin clean and well moistened, and keeping the fingernails trimmed to avoid excoriation and often comforting and preventing skin breakdown, and safety measures.
So this is the clinical data of my patient. Name, Mr. RJC. Address, Daro Dumaguete. Person or contact person, his wife, KP. Age, 54 years old. Birth date, February 14, 1966. Place of birth, Dumaguete City. Gender, male. Nationality, Filipino. Religion, Roman Catholic. Marital status, married. Educational level, college level. Occupation of office clerk. Health insurance, that's Fair Health. Source and reliability. Significant others 10%, patient 80%, patient's chart 10%. Date and time of admission December 14, 2029 in the morning. For the nursing health history, chief complaint, dizziness, severe abdominal pain, passage of blackberry scoops. History of present illness. 1 week prior to admission, patient complains of dizziness and passage of blackberry stools. He did not mind it, thinking maybe his blood pressure just increases. He was able to manage himself by that time. 3 days prior to admission, patient had experienced severe abdominal pain and dizziness, and the passage of blackberry stools twice. Few hours prior to admission, still in pain, and feel dizzy and was rushed to the hospital. Past health history. Patient claimed that he has hypertension and been diagnosed with diabetes mellitus since 27 years old. He had no maintenance on his hypertension for his diabetes, and he is taking metformin. For the family health history, patient has family history of diabetes mellitus, both parents' side. Patient mentioned that in his father's side has family history of hypertension, no other familial history. For the pathophysiology, My patient is 54 years old for the precipitating factors. Contributing factors NSAIDs use acetaminophen and metformin. As the patients claim that he was diagnosed having diabetes since 27 years old, and for predisposing factors that stress, diet, spicy foods, drinking soda and coffee. As the patient claimed and mentioned that he cannot live without coffee, and since he was young, he was used to go out and party with friends. So these are all factors that could lead to illicit effects on the cyclooxygenase 1, could lead to impaired mucosal defense to acid. Omeprazole is given to decrease the acid of the stomach, and impaired mucosal defense could lead to disruption of mucous barriers. These mucous barriers separate the external environment from the body's internal milieu. That's why cefuroxime and metronidazole are given, and it could lead to inflammatory effect on gastric mucosa. There will be inflammatory effect on gastric mucosa. Patient experience severe stomach pain, and Tylenol is given, and for nursing diagnosis, chronic pain. Nursing intervention, deep breathing exercises, and back rub massage. Inflammatory effect of gastric mucosa could lead to ulcer barrel sleep, and that's when a patient will experience poor appetite, and vitamin K is given. And for the nursing diagnosis, would be imbalanced nutrition, and the nursing intervention is instruct the client to avoid foods that causes gastric motility, and then weigh the patient. For ulcer barrel sleep, weakening and could lead to weakening and necrosis of the arterial wall, and development of pseudoaneurysms, and could lead to thickened wall ruptures leading to hemorrhage. If there is hemorrhage, it could lead to peripheral vasoconstriction, pale conjunctiva, and pale nail bed as the signs and symptoms of the patient. And for the weakening wall ruptures leading to hemorrhage, could lead to upper gastrointestinal bleeding. That's the patient. That's the reason why the patient was diagnosed with upper gastrointestinal bleeding. And patient was given tranexamic acid, and the signs and symptoms: body weakness, dizziness, black carrier stools, as the patient manifests, and then vital signs of the patient: temperature 37 degrees, and then pulse rate 102 beats per minute, and then respiratory rate 21 cycle per minute. Blood pressure is 180 to 100 mmHg. So these are all left untreated, could lead to shock, and it could lead to death.